Okay, everybody, welcome back. I hope you're all suitably refreshed for the final part of this afternoon's seminar. Without any further ado, I'd just like to go ahead and open it up to the floor. So please feel free to contribute with questions, ideas, suggestions, comments. Who would like to kick off? Okay.
Well, actually, it's addressed to the whole panel, but it was prompted by something that Dr. Nouri, yes, said about the patient. I was really interested that you said that you had asked him to alert you to when he needed. And actually, what I was wondering, how much of quality of life and well-being comes from people feeling empowered and able to participate and feel that they're also responsible for their own health. So that's for everyone, really.
Since it's prompted by me, maybe I'll start. So for this particular patient, because he had to travel quite a long way, that's what kind of basically triggered it. And initially we started off with kind of having appointments on the same day, but then one appointment would get moved. So we had set up first virtual clinics where I would basically have him on a list, but then he wouldn't be there because his respiratory clinic appointment was moved for whatever reason. So this is a discussion that we had. It's basically, he was quite happy about it. Not everybody kind of feels empowered enough. So I think it's something that needs to be individualized. It's not an ideal situation. What we kind of need to have is a operating system with a fail-safe. So to make sure that, people don't fall off our list. So I still have booked appointments for him. So that's basically, then I can make sure that he doesn't disappear because he's one of about 400 patients on my list. So, and time moves so quickly. So.
Can I add something to that? I completely agree with you. One of the things that we have in our clinic at Homerton are people called peer navigators. And the intention is, of course, it's peer support, but it's also about navigating the system and finding your way round it. And it's actually been incredibly helpful for people to then come back and be able to feel much more in control. But actually, what I'm thinking this afternoon is that all the peer navigators who've been working with us have all been what Chris would describe as sort of working age adults, if you like. And the Hall study, one of the things that came out of our findings was that people over 60 told us that they needed to be empowered by their own people who they recognise as themselves. So actually, maybe we need to be thinking about peer navigators across the life course in a way that then gives people the wherewithal and to do exactly what you've just said. So that's, I guess, the next step.
And it's kind of looking at these kind of lived experiences and shared narratives that people can identify with. So that's what kind of came out of some of the discussions that I've had with the South Asian community, because I work with them through the NAS project in London. So it's looking at everybody, what people want is narratives that they can identify with. So it's important that, if I say something that, what do you know, you weren't alive then, type of thing. So I think that's really important, but how we deliver that is kind of going to be quite challenging.
I have a question more than a comment. How do we think that we are empowering people to make choices? Because we keep saying patients' responsibility is people's responsibility. We work in partnership, but there are still relationships which are not based on equal stands, and we make the assumption that people are willing and able to empower themselves to a level that we believe is the right one. But what if someone doesn't want to be empowered in that way? And then we define them as a chaotic lifestyle, we strike them off. So there is still very much a reasoning of punishment, and I'm talking as someone who is a criminologist, so the language we're using is very much the language of punishment. So we end up punishing over and over again those who are not obeying to the rules that we set up. Right, you're kind of smiling, but
Look, I think in any form of healthcare, you can only impart so much knowledge to people, and it's dependent upon them whether they have insight and can take in that information and use it meaningfully to engage. And I think if I can use an analogy of hand washing for healthcare providers, and this was about 20 years ago, there's only so much information you can get about doing something correctly all the time that will then reach a plateau of any either professional or patients for that matter. We're going to reach that plateau where we're telling people to take responsibility for their health, and that's great. So we'll give all that information out, we'll continue giving it to people, but there will always be that cohort of people who won't or can't use that information to make their health better with the advice that's been given. And I think that goes for most health problems. You can tell someone about diabetes or their heart problems or their lung problems or their kidney problems, and I think there comes a point where we keep giving the information, we keep driving it, and all the health messages that are out there, but we will always reach a plateau where there are people who are in this totally different demographic groups that just won't be able to use that or take up the option of being able to look after health in the way we would expect them to do so.
The point I'm making is that we provide information which is a kind of linear kind of information, and the language is always the same. So it's all very well to say you go to see your consultant and you feel very empowered because you know everything about medications and blah de blah, but that implies that you have done quite a lot of homework prior to meeting your consultant in a language that is suitable to your consultant. And I'm talking specifically about the medical language, but also the English language, which is quite, is something that we need to take into consideration. So we cannot, we keep asking people to behave properly, take the medication, obey to this model, but we need to be much more flexible. If we're talking about, providing care, then we need to kind of provide the real care for real people, not for the image of people that we have, which are the pretty ones.
Yeah, I was just going to, because, we're doing a big bit of work at the moment on the patient survey, and one of the strands of that is about the relationship that people have with their clinicians. And that came from a lot of work with young people and people in the African population in Glasgow, where perhaps they didn't know that they were allowed to have conversations with their healthcare providers about different issues. And that's why the patient survey certainly your interviewers to see what can we do, what resources can we provide both parties to better that relationship so that each other knows what conversations can be had, and resources that meet the needs of everyone, not just, like Nicoletta's saying, not just one set of language, but is there a way that we can provide a resource to clinicians that they know this is the kind of language or this is what you should be using with this group of people, and is there a resource that we can give to people that are attending services that are like, these are the questions you can ask. Like, don't be frightened to say, I can't swallow my pills. So you've got a bunch of African women in Glasgow crushing their pills because they can't swallow them, but they also didn't know that they could have that conversation. So I think it's a fine balance to strike between making sure people have the right information, but also the responsibility needs to sit on the clinicians as well, that they have the right information to use.
Yeah, so I kind of wanted just to say that I think as healthcare professionals, we're not very good at communication with patients, and we're very didactic. And when we think about trying to promote behaviour change, that often falls kind of flat on its face because it's not collaborative. We don't communicate collaboratively. And just when everyone's talking, it made me think of being in a sexual health clinic, and you're told you shouldn't be doing this, you should be using a condom. We often instruct people, and we know, it's ironic, isn't it? We know that doesn't work, yet we still do it. That's how we often communicate with people in clinic. And I think one of the shifts towards trying to promote people taking responsibility for their own health is by communicating properly and effectively and having a collaborative relationship where people do feel empowered, like properly empowered, and that those conversations are conducive of behaviour change and not just telling people what to do. Because I'm sure. But, you know, people aren't stupid. They know what, you know, what they should be doing, what they shouldn't be doing. You know, people know that, you know, if you smoke, you could end up with cancer, or you could end up with, you know, X, Y, and Z, but people still behave like that. Yet if you have a different communication, like motivational interviewing, for example, style of communicating with people, you're much more likely to foster change and increase self-efficacy, and that in turn will help with people being able to participate much more positively in their healthcare. Yeah.
If I could just ask, and I made reference to the realistic medicine agenda previously. I think what you've described, Chris, as an idealised scenario, but that's perhaps more resource intensive, requires more time. Where do you think we're at? And I appreciate you perhaps speak more from the English angle, but I think it still be relevant. But where do you think we are between what currently happens and that ideal of approach? How much distance do we have to traverse? Who would like to have a go at that?
And again, I have to take an English stance because that's where I'm coming from. I think it's really interesting in that there are silos of working. So NHS England has a person-centred care unit, has a part of itself which is all about responsibility, well-being, but actually it's working on its own in a way. So we've only recently been able to coordinate the HIV commissioning unit with this amazing unit, and actually they're really interested in the HIV work because we've been doing an awful lot of that sort of work before, and they say, oh gosh, that's really exciting. So we've got to break down the walls within the system as it stands at the moment, because there's lots of things happening, but people are not seeing them and not joining them up. So it's having some clarity about who's doing what and then joining up the dots. Because I think there is some really good work happening, but it's not joining itself up properly yet, in my view, for the English system.
And I think to add on that, it's kind of also it's kind of bringing services back together. So kind of what we are seeing with where our HIV clinic and our sexual health services are kind of now separate departments, which basically means that people have to go to separate physical spaces to get the care. And we're trying to bring that back together, and it's all about kind of the funding. So it's kind of navigating the commissioning landscape, which is always changing. And the other thing is probably also kind of navigating the kind of language that we use, because quite a lot of it is kind of to deal with these outcomes that we are commissioned to report, and so that's what we're talking about, and patients kind of know what we're expecting, and they try to kind of give you the answer that they think you want. So quite often you get that because they don't want to disappoint you. So how do you kind of then you kind of need to have a system to make sure that your service is consistent, but you also need to individualize it, because otherwise it's not going to work. So that's the kind of complicated situation that we have to navigate. So it's basically kind of saying that we need to basically individualize and make it about people to make systems work.
Any comments from the floor? Have any particular questions? Anyone? Because one of the...
I was going to say, we've been talking about patient-centred care and healthcare We've been talking about patient-centred care and healthcare for a long time now. So I don't know why we haven't moved on. Absolutely unique to that individual. And considering we have got lots of good practice out there, the health system isn't very good about sharing. We're not very good about sharing best practice, the gold standards that we want to achieve. So I don't know why it's surprising to hear you saying, oh, I didn't know you were doing that. This is great work, because we've been talking about it for so long now. So it's really a comment more than a question. Why haven't we moved forward?
Cheryl's here, who's working on the long-term condition. Cheryl Gower's here, who's actually working. You actually precipitated that piece of work, the long-term condition management and the programme of care board and the commissioning structures to make that happen. So NAT pressed that start button, actually, and the person who's working on it is sitting there in the back. But I put her on the spot, sorry.
I was just going to say, a lot of the time when we talk about person-centred care, it sounds like because the care is so siloed, actually what you've got is a person in the middle and lots of individuals pointing at them, and it's not actually what it needs to be is a link of care that's person-centred. And that's, I think, why we talk about person-centred care so much, because we want it to be linked up. But at the moment, the way we talk about it is just, I always see it in my head as if there's a person in the middle and you've got a bunch of clinicians and healthcare professionals pointing at them. And it seems to be like person to healthcare worker, no matter where they are, and the healthcare workers aren't the ones communicating. And that's what causes the problems. It doesn't make it truly person-centred care.
I'm not sure this is the right word, but I think what we're actually talking about is functioning. And the reason why I don't really like the word is because it feels a bit sort of impersonal. But I think that until we get to a model where it's about what you can positively do rather than a sort of deficit model of where you're medically sort of not meeting a standard, we're sort of missing the chance to reorganise care in a way that actually focuses on what people want and need. And so often we hear people saying that HIV is actually the least of their problems. And actually, possibly the thing that is their problem is another comorbidity, or perhaps the problem is the fact that they've got insecure migration status or something. So the model, I think, perhaps decenters clinicians and changes the structure of who should be offering the care and who should be coordinating the care and how all those things work. And I think this goes back to the point at the beginning about the sort of wider complexity. And it's not, and the point actually that Jane made as well about the sort of broader structural sort of focus. And I'm not sure, you talk to individual clinicians and they agree, but I'm not sure collectively that we've got people on board for sort of really reorganising a model that really actually does put the person at the... I think that's why we're still talking about person-centred care, because we haven't actually got to a point where the person is really at the middle. We've still got the clinician and the system at the middle, and people are revolving around them rather than the other way around. I don't know if you have any comments.
Yes.
I think that's very fair, actually. I think it's because, and again, it's part of it is the way things are organised, which makes it complicated, but is not overcomable. It's overcomable if we want it to be. But I do think, I just want, before we beat ourselves up too much, I do think that if you go back over the years, the model of HIV care has been one of collaboration and much more partnership working than many other parts of medicine. Yeah. And I think before we say it's all terrible, we should actually reflect on what's going really well, because some bits are. I think for us in England, our pain is that things that were amazingly well joined up have been broken, and we're mourning that. But we have had the experience of things being quite well joined up, and they could be joined up a bit in the HIV model for other long-term conditions. I mean, for example, if people in the community adhered to their blood pressure medicine and had the support around their blood pressure, for example, like people with HIV do, I bet the stroke rate would go right down. But actually, that isn't the model. It's about, you go to your GP, you get a prescription. There's something that we do have that's really precious, really valuable, that we've carved together over the last 30 years out of this epidemic, that we should really value and use and disseminate, and we should be very proud of it.
Hi there. I just wanted to change tack a little bit, actually, and talk about things from a social care perspective. And start by sharing with you all a horrible experience that I had yesterday with a person that I support, who was having to move house because they live in a private tenancy and the owner of the house wants to sell it to make a stack of cash, as is quite common in Edinburgh. The person's reliant on welfare benefits, so couldn't afford a house removal themselves, so had to have their removal arranged by a local authority, a company commissioned by the local authority. Yesterday, the company came and the person's status was not disclosed to them, clearly, because it's not required. However, during the course of the move, a tablet was found under a piece of furniture. One of the removals team Googled it, discovered it was an antiretroviral, and a panic ensued, and they refused to move any more of the person's belongings because of the perceived risk of bodily fluids on the person's belongings. Now, I'm totally raging, even just talking about, even though it's been 24 hours later. There's so much that is wrong with the whole scenario, and trust me, it is not over, because I am going to take it as far as I can on behalf of the person that I support. But I guess that for the purposes of this seminar, it's highlighted a couple of things to me in my 24 hours of, reflection and digestion. And I think that, to me, these guys that were involved are all in their 20s. I'm like, what's going on in their schools? Why did these young people think that they could contract HIV from handling somebody's belongings? It was just appalling. The total overt discrimination and stigma that this person was subjected to was disgraceful. And because this person lives in poverty, they didn't have the consumer power to say, piss off, I'll get another company to come and do my removal, thank you very much. And there was also the pressure of the letting agent wanted the keys back that day, etc., etc. So you can see how, in terms of quality of life and the stigma and the mental health, how all of these sort of things all impact. And, I think that in this scenario, we've managed to kind of buffer the impact to that situation, because I can advocate on behalf of the person that's in the middle of all of this. But that's not really often seen in terms of through the social care lens as something that's absolutely an essential service for people, because it's focused on food, meds, getting up, getting washed, getting dressed. And that's, to me, is life. That's not quality of life. And, unfortunately, in this environment, recurrent year-on-year budget cuts, ageing population across the board, more and more people that are living longer with multiple comorbidities, mobility issues, all the rest of it. We already have quite a lot of pressures on the social care system. And I just think that it's quite sad, really, to think that people are not going to be given the advocacy that they need to try and challenge that stigma. And also, I was thinking too, when we were discussing this, that, in terms of social care commissioning as well, the care of people living with HIV is no longer protected within the healthcare professional bubble or the social care and voluntary sector bubble, because local authorities are commissioning more and more private companies to be providing care and to be providing services like I've described, they're being delivered by everyday members of the community who still clearly hold some really ridiculously outdated ideas and beliefs about people with HIV. So I think it's really great, all the stuff we've been speaking about today, and I do totally think, it's the right way forward, but there just seems to be a lot of basic stuff that really needs to be done to underpin that too.
I'm seeing a lot of nodding heads. Yeah, Nathan, I think you want to come on.
Yeah, thanks for raising that. I don't think I've heard in my 2 years at HIV Scotland of a story that doesn't involve needles or medical equipment of someone being discriminated like that so badly and so blatantly. Most recently, we have been able to change all of the guidelines for tattoo studios across the UK, working with the British HIV Association, because of stories about people going into tattoo studios and being discriminated against. The point you make about education and what's happening in schools, I shook my head at that on the basis that nothing's happening in schools. There is no HIV education in schools because I think either teachers don't think it's an issue or we're still in the past. There's new relationship, sexual health and parenthood education being published in the autumn this year that does mention things like U equals U and PrEP, but that's only going to be useful if the teachers delivering it know what those things are, and simply coming out with a guideline to say this is what you should say doesn't work when you're asking computer teachers to teach guidance classes about the menopause and HIV and female genital mutilation, which is what computer teachers come to us whenever we talk about education. Computer teachers come and say, well, come and deliver lessons for us because I have no idea what I'm talking about. And I think that's the disparity we've got in our education service, is that young people aren't getting that education. And we talk about the hangover of the 80s and the campaigns that happened in the 80s. And so what we've got now is actually no one or very few people that actually know what it's like to live with HIV in the modern day realities, apart from people that have an interest and people that are living with HIV. And that's why a public campaign is needed, but also when things like this happen, we deal with them appropriately. And I'm happy to touch base afterwards to look at how we deal with that in a local government procurement way, because that's how you challenge those private businesses that are dealing with members of the public and discriminating against them. So I'd love to work with you on that. And the point you make about advocacy, I think, is also very important. We discount advocacy as a vital tool to someone's quality of life so often because it costs money. And it doesn't necessarily come out with an outcome that is tangible in a way that giving someone medication is, or making sure that they've got money is. And advocacy works, and I think this is sometimes where we've had some challenges with funding an organisation like HIV Scotland that does policy, advocacy and campaigning work, is that advocacy can be one person phoning you up because they've got an issue, or it can be an issue that deals with everyone. And there's, no matter how long something might take to deal with, there isn't that sort of level playing field with how important that individual feels for that advocacy. So I think what we've got a great opportunity at the moment with the revitalisation of the HIV response in Scotland through things like Fast Track Cities and the new sexual health and bloodborne virus framework that will be that's being worked on at the moment. We've got a meeting with people living with HIV in the government tomorrow. So happy to continue to put forward the importance of advocacy in that goes beyond just involving people living with HIV, but ensures that they have the services for people to advocate for them. And the final point is just about changing laws and changing guidelines, is that these stories, as much as they are horrific, and we don't want them to happen, when we know about them and we can do things about them, we change laws, we change guidelines, and we change minds. And that's what I think is the important bit of advocacy work that an organisation like HIV Scotland can do with people that are involved. So thanks for bringing that up.
Can I just mention something on that? I'm involved with everything in Glasgow, and it seems... I feel like I want to sing a song now. I hate these things. Myself and my colleague and Julie, they were all from Terence Higgins. We are from the West, and she's over in Dundee. But we'll not talk about that. I'm involved in a programme called Positive Voices, which goes out to schools. And fun enough, you should mention that, you know, from now until the end of the month, I've got 2 talks I need to go to down in Prestwick in Ayrshire, where we will sort of facilitate, you know, the sort of idea of you versus you, and the likes of myself and another guy will be talking about our experiences of catching HIV and trying to educate the youngsters in that school. You know, and this is the way that this programme was set up, and this is what 10 seconds and Callum are surely backing up, and this is what we're trying to do in the West Coast. I don't know if there's anything like that in the East Coast, I don't know, but this is definitely something that's been happening for 2 years or something like that. So this is why I want to get involved, you know, to try and educate the young girls. Being a teacher myself at one point, that this is what I want to do now, you know, and I think, you know, hearing sad stories like that sort of makes it all sort of worthwhile, and it seems to be maybe a West Coast thing rather than an East Coast, you know, so.
I think projects like that obviously are very helpful, and it's what teachers are wanting as well as the young people that want it. Like when you say computer teachers don't want to be delivering these lessons, and that's there is lots of work happening about education that we're leading on. A report that will be coming out in the next couple of months after we surveyed 3,000 young people about what they want from sexual health lessons. So that's a really vital piece of work that will hopefully lead to more programmes like that being set up, because it shows a need for things like that across the country. But I think it does, when we look at how that impacts on quality of life, not having things like this happen to people improves people's quality of life. The fear of going to a service because of a fear of discrimination is what creates social isolation and what creates the self-stigma that perpetuates a poor mental health outcomes for people. So we do need that advocacy and these programs to better everyone's quality of life, because the fewer that this discrimination is able to happen, the less the fear of that discrimination means that people are stuck in their house because they don't want to be discriminated against because of their status. So I think it all...
in their medical health care plan too, because
Always.
that's when people are most likely to go, oh, I don't know want to take my ARVs anymore, what's the point? You know, so it's all very much holistic.
But we even saw in the data that came out from Health Protection Scotland that young people are the most likely to not take their treatment and are not accessing services because of the stigma, and that's going to impact on their quality of life in the longer term, because the longer they're not taking medication, then the longer the virus has to take hold and impact on their health. So I think it is all related to stigma, and we need to think stigma runs through every bit of work that we do. And measuring quality of life and measuring stigma. One of the things that the current framework for the Scottish Government, outcome 4 or 5, always mix them up, are classed as aspirational by like policymakers, because we've not worked out how to measure them. So because we've not worked out how to measure them, we don't know how to work towards reducing stigma. And I think that's, I mean, one, ridiculous, and two, a challenge when there are tools to measure stigma, and really it's about speaking to people. The problem, I think, has been not willing to put the funding behind that speaking to people and working out what stigma is experienced. So we can only do it at the moment with looking at things like there's the UK Stigma Index, which had a cohort of around 130 people from Scotland in the last cohort, and it's currently running at the moment for the new version, and also looking at public attitudes. And we've done massive Scotland-wide surveys around public attitudes to HIV, and if they know about U equals U, and if they would be in a relationship with someone, or if they would work with someone, or if they would kiss someone with HIV. And all of these things impact on what stigma is, but also the stories of discrimination that you've told. So I think there's so much of this that impacts on quality of life that we need to stop thinking about ending and eradicating stigma as aspirational and just get to work.
Okay, so I enjoyed the talks today. I really liked the cyclical way that you joined the 90-90 with the fourth 90. It was really quite interesting. I do worry about those 10, 10 and 10 that we're not actually reaching. And I think UK-wide, obviously, we are reaching 90, 90, 90. And in Scotland, we're doing that as well, but maybe not quite as well as the rest of the UK. So what can we do in Scotland to actually get up to the same level as the rest of the UK? And also, what tool do you want us to use to measure quality of life? Because I'd quite happily do it in my clinics. I'd quite happily do it, but you need to tell me which tool I need to use, because I think we should do the whole, do the same everywhere.
Okay.
I think this is one of the reasons why we're having the seminars is to look at those tools and see what might be the best one to use. And I know that there's a move from people living with HIV in London that want us to use the Australian tool because that's been developed by people living with HIV for people living with HIV and using that as a worldwide one. I think there's probably benefits for all of them, although except for maybe the first one because it's quite medical. But yeah, I think you're right. I think when it comes to the 90-90-90 targets, we're certainly failing on the first one quite a bit in different areas. So in Glasgow, we're probably not meeting the 90-90-90 targets on the first 90. And I think a lot of that comes down to access to testing. Scotland is a country where you can't access testing at home, where you can in England for free. And I think that's a challenge when you've got struggling services that are not being able to meet the demands put on them. So if you think about services like Waverley Care's drop-in service or THT's drop-in service in Glasgow, they're getting a demand of twice what they can cope with, but then having to turn people away without any follow-up. So they're not getting a test to take home. So you could have 8 people a week having got the courage to go for a HIV test and then being turned away and not coming back. And those are the challenges that I think we have in Scotland around access to testing and I know that it's being looked at now, and I know that certainly looking at getting to zero by 2030 is an ambition that the Scottish Government are looking to see if they can get there, but it will take extra work. We know that the 10-10-10, although in Scotland I think it's 9-5-3, are complete diverse population. It's not that we're missing one community, we're missing people from all communities, and so we just need to do a bit of extra work. And I think one of the things, I've talked about this before, is we risk complacency because we met those 90-90-90 targets. We risk that thinking that that's the job done, and that's why, you know, when we came out with our new strategic plan and wanting to get to zero, it was all about that we need to take the next step and we need to reinvigorate the response, but we need to think about stigma as the impact to why we're not reaching those people in those numbers that we're not meeting. And without any coordinated response to stigma, we'll never be able to reach those numbers. So I think until there's a public awareness campaign about HIV and until we systematically look at every single level of where stigma is impacting. So that's in the law when we're criminalising drug use and sex work, when it's in our organisations when we have dentists pushing people living with HIV back to the last appointment of the day, where it's within our communities that are affected by HIV and not affected by HIV, and then at an individual level. Without systematically targeting stigma at each of those levels, we're never going to get to end stigma and then get everyone that needs to be tested, and then everyone that's HIV positive on treatment. And that's what's causing that divide at the moment. And I wouldn't say we're too far off the rest of the UK. I think London, because of the numbers and because of the investment that's gone in London, make the rest of England look better than it might be. And I think so we shouldn't look bad at Scotland, but I think we've all got these challenges that need to be tackled, and without that systematic approach, we're never going to manage it.
Thank you. Yes.
Living older with HIV and feeling ill, sometimes you wonder, like myself, we need to self-educate ourselves, because we wonder, are these ailments because we're getting older? Or are these ailments because we've got HIV and we've got side effects from all the multiple things we're taking? And sometimes you feel like, oh, I'm not going to go to the doctor, and then sometimes and then it develops. So I think a lot of it, this is great today, and learning the circle you showed, but sometimes you get worried about going on internet and reading things, and sometimes when you're given new medication, the first thing you don't do is take out what's the side effects, because, you know, that's what you'll think. So it's self-education as well.
We are unfortunately rapidly approaching the conclusion of the seminar, but before we get to that point, I would just like to give an opportunity to each of our speakers this afternoon to make a few closing remarks. So starting with you, Kristen.
I'll you go first.
I think I sort of said what my closing remarks were in terms of that, you know, we need to not think of stigma as aspirational. We need to look to get action on that and look at creating a new data set in Scotland for what quality of life means for people living with HIV, because that's I think the important thing that will mean we can get investment in the other services and advocacy beyond just a medical model. So I think it is a case of let's get to work, and just really want to pass my thanks on to everyone that's been able to make it today.
Thank you to everyone who made it today, and to our speakers. I think what I want to say is, once again, let's make sure that this is not one fit-all approach when we think about aging with HIV. Every single person living with HIV has, as we mentioned several times, lived experience. They have a story, they have a body, they have a soul. So the approach has to be ad hoc for the person. And it's not the person's responsibility to adhere to a model that is up there. It's the other way around. That's kind of how I would like to end this.
And I think I'd like to second that and say that, you know, we need to, as care providers, think about having a care plan that we are individualizing with patients and work together. So they don't fit with us, we need to fit with them and make sure that they kind of have a discussion about what priorities are. And the other thing with regarding to getting to zero would be that we need to make testing accessible. And that means that having not one model, but actually making sure that there are several avenues that would be available for people to access testing, and then to remove barriers in clinics. Because if somebody has a bad experience being turned away from a clinic, they're less likely to come back. So I think that's something that is kind of a key thing. I know people are struggling with capacity, but that is our responsibility to improve access to our services.
Thanks very much. And I'm cognizant of the fact that the title of this is 50 plus, and I think it is important that we try and wind up a little bit about what's special about being 50 plus, because and I think what you've touched on, the fact that there are people who are living with HIV and are older are likely to have more problems, more health problems, more issues. Have we got a system that is either measuring that or is able to deal with that? And I don't think we've quite got that right. So going back to your point about what tool do we use, I think perhaps the next thing is to have a kind of round table about what would be most useful. What is the metric, or what are the metrics we need for people living with HIV over the age of 50 so that we get it right in the way that you're talking about? And that needs to be a conversation across the system, and not just with healthcare providers.
Perfect. Yeah, I've thought of something. I guess, you know, thinking about, I think, you know, stigma is right at the heart of feeling depression and psychological distress with older adults living with HIV. And also just to be mindful when we're thinking about developing services, as you know, the cohort is getting older, that we actually think about the interventions that we're offering and to make sure that they are appropriate and evidence-based. Thank you.
Thank you very much. Just a final reflection from myself from the politician's perspective. I think we're all aware of the many intractable and challenging problems that we face in healthcare and public healthcare across Scotland and the UK. There are many wicked problems as such, where there is no easy solution. An ageing population, the obesity, type 2 diabetes, mental health and its relationship with the changing nature of work. A reflection I took from my experience working with Hepatitis C Trust, and it's one I take from my engagement here today, is that we are in a position within a generation to consign HIV to the history books. I don't want to suggest it's simply just a managerial problem, but compared to where we were a decade ago, certainly compared to where we were 3 decades ago, people born today, by the time they get to 50, we'll probably have to look to the history books to read about HIV. And I think as such, when with all of the challenges that we face in public health, when we have an opportunity like that, it's incumbent upon policymakers and it's incumbent upon government to snatch for that, because we have far more complex problems awaiting us and coming down the track. And I think this process today, and as part of this overall seminar series, can play a major role in helping to shift the narrative that exists within our public conversations. I was shocked and appalled to hear the account of the individual that was relayed earlier. And it's sadly that speaks to the amount of work that we're still to do. And there's a role for politicians there as well, and I am hugely sympathetic to the need for a public information campaign. Again, this is something that resonates with me from my experience working with the Hep C Trust. The number of people who are unaware of the treatments that are available now and still believe it's a year on interferon and consequently do not seek to engage with treatment. So we have the means there, we have the resource, and the challenge put to me and to all my colleagues in the Scottish Parliament and to politicians across the UK is to provide that will and that political motivation to go and achieve something that is absolutely within our grasp. And so it's important that we keep pushing, because we are pushing at an open door, and it's important that we keep making those efforts. Finally, I just want to thank everyone who has come along and given up their time this afternoon to take part. I'd like to thank all of our speakers, Professor Anderson, Dr. Norrie and Chris McCormick. I'd like to say a special thank you to Nathan and all at HIV Scotland for the efforts that they've put in this afternoon in making this happen. It's not easy organising events like this. And then finally, I'd like to thank Gilead and everyone else who has supported the event. I'm very much looking forward to the future seminars, and I'm hopeful that we can get perhaps some more of my colleagues in the Scottish Parliament along here for the future seminars as well, and to engage and to hear firsthand. But thank you everyone for coming along and making this a very informative and very educational afternoon, and I wish you all a safe journey home. Thank you.